Okay, so in class we left off talking about platelets. What I want to point out about platelets and repeat is that platelets come from a cell that was originally hematopoietic stem cell, just like everybody else, and it is going to mature into a myeloid lined cell, then a megakaryoblast, and eventually a megakaryocyte. Fragments of this cell are what's going to end up in the circulatory system. What happens with platelets is the cell is so large, the megakaryocyte is so large, when it goes to squeeze into the circulatory system, it breaks apart. So what we have left behind is a fragment of a cell. And that's what they're trying to depict in this beginning portion of the diagram on page 735. So this is a cell fragment. The stimulation, the hormone that is going to cause these cells to mature into megakaryocytes and eventually platelets, is called thrombopoietin, and it is secreted by liver cells. This is going to help with blood clotting, and typically we are going to see an increase in thrombopoietin when we have a cut or a breach in the circulatory system that needs to be addressed. General lifespan of a platelet is very short, 7 to 10 days, and spleen and liver are again going to be good about getting rid of old platelets from the circulatory system. So again, things to remember about platelets. Platelets are fragments of cells. Thrombopoietin is the hormone that is going to be secreted to cause the formation of platelets. If you look on page 736 and 737 in your textbook, you're going to see the whole group of cells that come from hematopoietic stem cells. Again, they've broken it down in the PowerPoint for us, but everything is on one or two pages, page 736 and 737. The nice thing about this is we see all the cells in one place. We see what they look like. We see who they come from. Remember, all of these formed elements come from hematopoietic stem cells. So look over page 736 and 737 to sort of tie everything together in our minds. The next thing the book talks about is the role of platelets. Before I go on too far, I also want to point out that diseases of the white blood cell lines are referred to as leukemias. And the A&P in the Real World blurb for you to look over is on page 738 in your textbook. Basically, the leukemias are named for the type of white blood cell they affect. So if it's a myeloid leukemia, it's going to affect the myeloid precursor cell line. They talk about the difference between chronic and acute leukemias. And acute leukemias happen very quickly. Chronic leukemias can go on for long periods of time. And again, typically named for the type of cells they affect. They do a little blurb on acute lymphocytic leukemia, and this is actually going to affect the lymphocyte line. So that's what a leukemia is, basically a cancer of blood cells, or white blood cells in particular. Next thing you talk about in your book is something called hemostasis, and that's the fancy science name for blood clotting. This little chain of events is the basis of the discussion. Starting on page 738, we're going to talk about the steps involved in blood clotting. The first thing we see is vascular spasm. Then we see the formation of a plug, a platelet plug. Coagulation refers to making those proteins we discussed today that are normally floating around in liquid form in plasma into solid form, and that end product is called fibrin. That's going to act almost like a plug or a band-aid. I hate to call it a plug because platelet plugs are a little bit different than coagulation. Once we've healed the tissue underneath, then we need to go through a process called clot retraction. So we can't just rip off the Band-Aid and let it go into the circulatory system. We have to actually dissolve away that platelet plug and coagulation that we've created. So that plug is sometimes referred to as a thrombus. So we need to go through a process where we're going to break apart the thrombus. And that process is called thrombolysis. So in your textbook, again, spanning from page 738 to 739, we see the steps in visual form of hemostasis. The first part of hemostasis is called vascular spasm, and that discussion in your textbook begins on page 738. So this happens when the blood vessel's actually injured. There's a cut or a breach of some kind, and we have to respond to that very quickly. What happens is blood's going to start leaking out, and two responses need to happen. That vasoconstriction, so blood vessels are going to constrict, and that's going to create an increase in tissue pressure. That's going to cause a decrease in the blood vessel diameter. This is, think of it as bringing the cells closer together as much as we possibly can to minimize the loss of blood. The next thing that's going to happen is platelet plug formation. So this discussion starts on page 739 in your book, and that's the second part of hemostasis. So basically, the tissues, when they are injured, they give off chemicals, and those chemicals are going to act as attractants. They're going to act as attractants not only to help plug up the hole, but they're also going to act as attractants to other white blood cells in the area. So the term chemotaxis is going to apply here as well. So when the vessel injury is exposed, collagen fibers cause those endothelial cells to produce a chemical called a von Willebrand's factor. That is going to help bind the platelets. So that's that chemical message that's going to draw platelets to that area which has been injured. And it's going to help activate those platelets and cause them to stick together. They're going to stick to exposed collagen in the injured tissue underneath. So basically we're breaching the endothelial cells and exposing those platelets to the connective tissue and the collagen fibers underneath. So those activated platelets are going to release granules, and the contents of those platelet granules are going to activate and attract more platelets that are going to stick or aggregate and form a platelet plug. So first, in platelet plug formation, we have to plug up the hole with platelets. The next part is the confusing part, and this confusing part is because there's so many different chemicals that are involved in the formation of a fibrin clot. And a fibrin clot looks a lot like spider webs almost. We're going to take normally liquid form proteins, and we're going to, through a series of chemical events, cause them to form these fibrin threads. I am not going to make you know all of these different factors and all of the different order of the factor activation. I do want you to have an appreciation for the fact that the coagulation cascade is very complex, and anytime we're missing factors, we won't be able to form a clot. So clot inhibition and anticoagulants that we might use are going to affect one of these different factors or several of these different factors in a cascade in any given order. So I think your book talks about some anticoagulants. Just flipping through. I hope they talk about anticoagulants. But if I don't want clotting to happen, if a patient, for example, has a disorder where they start forming clots when they shouldn't, we are going to administer an anticoagulant. Two of the most common ones are heparin and Coumadin. Heparin is an intravenous anticoagulant, and Coumadin is an oral anticoagulant. There's a couple of newer ones on the market, but beware of those because unfortunately, if something goes wrong and I need to stop the action of the heparin or Coumadin, all I have to do is administer vitamin K. And vitamin K is going to help us get back to more normal clot formation. The other one's not so easy to reverse. So if something goes wrong, we might see that our patients are going to bleed a lot longer than we want them to. What I'm going to do in my email to you with your essay questions is I'm going to give you an abbreviated synopsis of coagulation. There's a couple of steps that I feel is important for you to know, and there doesn't seem to be an abbreviated form of it in your textbook. So I will give you that abbreviated form in the email when I email you with your essay questions. So in the diagram on page 740 are all the specifics of the formation of a fibrin clot and all of the different factors involved in that formation. We call these factors clotting factors. And in your textbook on page 742, there's a list of about 13 clotting factors. There used to be 13, but now we don't have a factor 6. So we've kind of updated our information and have 13 numbered, but only 12 clotting factors. Again, I'm not going to make you memorize the clotting factors, but I want you to have an appreciation for the fact that all of these factors are involved in the eventual formation of a clot. The other very important thing in clot formation is calcium. Calcium is an important player in the formation of a clot. So platelets are going to start activating these pathways. They describe two different pathways. One's called an extrinsic pathway and one is called an intrinsic pathway. When we think of the extrinsic pathway, think of something happening from the outside that damages cells and causes clots to happen. When we think of intrinsic pathway, think of the steps involved inside the body that are going to result in the formation of a clot. Both the intrinsic and extrinsic pathways have a common pathway, and that common pathway turns thrombin, fibrinogen, into fibrin. And this basically is going to form those fibrin threads and glue those platelets together. So in my synopsis, basically I want you to understand the difference between the extrinsic and intrinsic pathway. And then I want you to understand the common steps that are both going to result in fibrin platelet clot. Again, I will send you that in the email that I send you. So this describes the extrinsic, intrinsic, and common pathways. And the end result looks like spider webs. The reason there are red cells in there is because they get caught up in the sticky fibrin threads as they pass by. So in this diagram, this is an actual scan where we see the fibrin threads, these pink things, and then we see a caught up erythrocyte, platelets, and leukocytes that kind of get caught up in the plug. The next part of this chain of events, and this is the clotting factors that are listed for you in table 19.2. Again, no need to memorize them. Just understand they're involved in the formation of that fibrin clot. Once this coagulated clot has done its job and the tissue underneath has been repaired, we have to break this down and send it back into the circulatory system. So hemostasis part 4 and part 5, described for you on page 743, describes how we break this clot apart and then send it back into the circulatory system. So clot retraction and thrombolysis. So the first part, clot retraction, we're basically kind of slowly removing the Band-Aid, not quite pulling it off yet, but slowly removing it and kind of squeezing all the liquid out of it. And that's what's happening during clot retraction. And then thrombolysis involves some different chemicals that are released by the endothelial cells. One of them is called tissue plasminogen activator, or TPA. And you might have heard this when someone comes into the hospital who is having a stroke, for example. If there's no blood vessel damage, and we know that it's just a clot that needs to be broken down, we can administer TPA and help to break down a clot that is possibly causing stroke symptoms and help a patient not have as much damage to areas in the brain that are being affected by that clot causing stoppage in blood vessels in the brain. So that's what TPA is, tissue plasminogen activator. Problem with this is we have to make sure that there's no breaches in blood vessels. If there's a breach in the blood vessel and the patient is bleeding, we can't administer TPA because that bleeding will be enhanced, and that particular treatment we can't use for that patient. So TPA is then going to activate something called plasminogen, and then plasmin is going to degrade fibrin Plasmin is formed from plasminogen, and that's going to degrade the fibrin and help the clot to dissolve. So endothelial cells release TPA. TPA is going to activate something called plasminogen. And then plasminogen, the presence of plasminogen, is going to help with the formation of plasmin. And that's going to help break apart the clot. So now it can go back into the circulation without causing any issues. So some of the different thrombolytic agents and regulators of clot formation are listed here. Regulators of clot formation: prostacyclins, antithrombins, heparin sulfate, protein C. These are some of these different regulators of clotting and clotting disorders. Those are described for you on page 744. And we see this table 19.3 on the bottom of 744. It also describes under disorders of clotting some of the different bleeding disorders that might be a result of deficiencies in certain proteins, or might result in deficiencies of proteins due to genetic factors. So they talk about hemophilia A and hemophilia B. You should understand the term thrombosis, thrombus, and thromboembolysis. And those are defined for you on page 744 under disorders of clotting. Big picture for you on page 745 shows all of these steps together. And the last part of the discussion talks about blood typing. Before I go on to blood typing, which can be a confusing concept, I want to point out the APII in the Real World on page 746. And this talks about some anti-clot medications or anticoagulants. Heparin, again, is that IV form, and warfarin is another name for Coumadin, and those are oral medications. So starting on page 746, we are going to talk about blood typing and matching. I touched a little bit on the formation of antibodies in blood to help neutralize foreign substances. For this discussion, let me blow up the screen so we can see it a little more. When we talk about blood typing, we need to take into consideration the fact that our bodies will recognize foreign things that come in and will try to protect us from them by producing antibodies against any foreign antigens. So the two terms, I'm going to talk about this a lot when we talk about the immune system, but antigens are proteins on the surface of cells, and antibodies are chemicals that we produce to help neutralize antigens. So it's kind of like a lock and key type thing. When our bodies recognize a foreign protein, say on a virus that comes into our bodies are then going to produce antibodies against those foreign proteins or antigens. Oh, hold on, gotta answer the phone. All right, sorry about that interruption. Okay, so the confusing part of this section is the difference between an antigen and an antibody. They both are anti. You need to understand that antigens are proteins that we find on the surface of cells, and antibodies are chemicals that are made to neutralize foreign antigens. When we talk about blood typing, something occurs that's kind of strange, and it only occurs in this case in the human body. And what happens is we make antibodies against antigens of the blood typing that we do not have. Confusing, I know. There are two different types of antigens that we can find on the surface of cells. And when we talk about antigens with respect to blood typing, we refer to them as the ABO antigens. So the two different types of antigens that you might have, and we're talking about these antigens being on the surface of your red cells, are type B antigens or type A antigens. And again, these are proteins that we make based on our genetics that are on the surface of our red cells. Sometimes we receive genetic information from our parents that cause us to make both antigens, and we can have A and B antigens on the surface of our cells. And sometimes we get information from our parents that cause us to produce neither antigen, A or B. We call this type of cell an O cell. The O cell has other antigens, but they're not A and they're not B. The other antigen with respect to blood typing that's very important for us to determine whether we have or not is an antigen called the Rh antigen. Another name for the Rh antigen is the D antigen. We'll see this when we type blood in lab. The antibodies that we use to determine whether or not we have the antigen on the surface of our cells are called anti-D antigens or anti-Rh antigens, or antibodies, excuse me. I hope that didn't confuse you. So let me reiterate that. We can have B antigens on the surface of our cells. We can have A antigens on the surface of our cells. We can have both A and B antigens, or we can have neither A or B antigens. If you look on page 747 in our textbook, we'll see all of the different possible combinations there are for human blood type. If I have this third antigen on the surface of my cells, which is called the Rh antigen, we put a positive after our blood type. If I don't have that Rh antigen on the surface of my red cells, we put a negative on our blood type. So a person who has A and B antigens on the surface of their cells, but no Rh antigens, has a blood type of AB negative. This person has neither A nor B antigens, but has Rh antigens, they are O positive blood type. Let me just go back to the big chart. So these are all the possible combinations for humans. If I have AB positive blood, I have all three antigens on the surface of my red cells. A, B, and the Rh. Remember, the Rh is either, if I have it, it's positive. In this case with AB negative. If I don't have it, it's negative. So if I have only A and B antigens and no Rh antigens, I am AB negative. If I only have A antigens and the Rh antigen, I'm A positive. If I only have A antigens and no Rh antigens, I'm A negative. B antigens and Rh antigens, I would be B positive. B antigens and no Rh antigens, I would be B negative. If I have O or blood type O, I don't have any A or B. If I'm O positive, I have the Rh antigen. If I'm O negative, I don't have the Rh antigen. The next thing they discuss has to do with antibodies. Now, normally, I will not produce antibodies unless my body has been exposed to foreign antigens. But for some reason, our bodies produce antibodies naturally to the antigen that we do not have with respect to blood type. I'm going to skip over here. This only applies to A and B antigens. Example, and let's look at that chart on page 747 again. I'm going to go back to it. I know it's small, but look at it in your book while I talk about or explain. I will make, and I'm going to skip over to this A positive. I will naturally make antibodies against the A or B antigen that I don't have. In the case of AB positive, I have both of those antigens on the surface of my cells. So I won't make any antibodies to the A or B antigen. In the case of A positive blood, I don't have the B antigen. So what I'm going to do, and we don't know why this happens, I am going to produce anti-B antibodies. And they're going to be floating around in my circulatory system. So I will make the antibodies to the antigen I don't have. I'm skipping down here to the B positive. A person who has B positive blood doesn't have the A antigen. Therefore, they're going to produce these naturally occurring antibodies called anti-A antibody. And that's going to be floating around in the circulatory system. When I give someone else my blood, I have to take this into consideration. I have to make sure that my antigens and antibodies match the person's blood that I'm receiving. For example, if I have A positive blood, I can't give my blood to a B positive person because my blood has A antigens on the surface of cells. And that B person has antibodies to the A antigen in their circulation. I'm going to skip over to this little diagram. So if I were to give somebody who has B antibodies B cells, we're going to cause them to clump. So if I gave, I don't know who Sue is, but let's talk about Sue. There's probably a little scenario in your book. So anti-B antibodies that Sue has would agglutinate Sue's erythrocytes. When I test to see what your blood type is, I actually use antibodies to do that. The reason I'm popping this up is because I want you to see what happens when antigens and antibodies react with each other. When I add A antibodies to a cell of blood type A, the antigen and antibody are going to react and cause large clumps to form. The person who has type A blood won't react to anti-B antibodies because they don't have any B antigens on the surface of their cells. Remember, a person with type A blood also has type A antigens on the surface of their cells and produces naturally occurring anti-B antibodies. Person with type B blood has no A antigens on the surface of their cells, but they do have B antigens on the surface of their cells. Remember, a type B person will produce anti-B, anti-A antibodies, and they will be circulating in their blood plasma. A person with type B blood has B antigens on the surface of their cells. A person with type AB blood has both A and B antigens on the surface of their cells. So when I use the antibodies that come in a tube, those cells are going to react with both anti-A antibodies and anti-B antibodies. This person will not produce anti-B or anti-A antibodies, and they don't have that circulating in their plasma. And then a person with type O blood will actually produce both anti-A and anti-B antibodies. So the discussion of blood typing and blood matching is a discussion of these antigens on the surface of cells. One of the little bit confusing things that they put in this chart makes you think that these antibodies are present in plasma. And again, I'm referring to chart on 747. When I talk about naturally occurring antibodies, the only time we're going to see these antibodies in a person's blood naturally are against the A and B antigen. the one that they don't have. You will not produce anti-Rh antibodies if you don't have the Rh antigen. So if you're O negative or A negative or B negative, you won't produce anti-Rh antigens. The only time you're going to produce anti-Rh antigens is when I expose my body to an Rh antigen, just like a virus almost. This comes into play when we talk about our donating blood. It also comes into play when mothers give birth to their children. If we have an Rh negative mother and an Rh positive father, we have to make sure that we prevent mother from producing the anti-Rh antibodies. We administer something called RhoGAM, which is a big, huge dose of the anti-Rh antibodies when mother gives birth. Because no matter how hard you try, your blood is going to mix with baby's blood, and baby's blood is going to mix with your blood during childbirth. If you have an Rh negative mother that has Rh positive blood introduced into her system during childbirth, she will produce anti-Rh antibodies. Again, Rh doesn't follow the naturally occurring rule. Subsequent babies after that, unfortunately, the anti-Rh antibody can pass through the placenta and into baby's system during fetal development. So if an Rh negative mother produces those anti-Rh antibodies, she can cause a transfusion reaction, or a reaction where her blood, which is supporting a child during fetal development, those antibodies actually attack that child's cells. First pregnancy, no problem. Every pregnancy after that, problem. And typically results in death to the fetus. So now that we understand how these antibodies and antigens react with each other, we give, again, Rh negative mothers antibodies in and around the time they give birth, preventing them from making anti-Rh antibodies. When we are trying to match donors, we want to make sure we match the profiles best as possible. And we don't want to give an Rh negative person an Rh positive blood, because they will produce antibodies against the Rh antigen, and it can cause all sorts of problems down the line. So in this chart, back to the chart, we can see on this side, may receive and may donate to. Look that over, understand why. An Rh negative is always going to get an Rh negative blood. If I have AB negative, I don't have, and this shouldn't even be in here, this is making me mad. You don't naturally produce these, but you have to pretend that you would if you got an Rh positive blood. So think about the antigens on surface of cells. Think about how my body will recognize them. If I don't have them, I will recognize them as foreign and I will make antibodies against them. In the case of A and B, I will make antibodies against the antigen I don't have. And that's why we need to match so closely blood types during transfusion. Because the person already has, if they don't have type A antigens, they already have antibodies ready to attack those foreign antigens when they enter. Okay, so hopefully I haven't confused the living daylights out of you. What I suggest that you do is read over this section on page 746, blood typing and matching, and take into consideration the types of antigens and antibodies that we would see in someone's blood, and making sure that we don't give anybody antigens that they don't have on the surface of their cells. The other thing to take into consideration is the fact that when we give patients blood, typically we give them only the red blood cells, and we rinse off all the antibodies and rehydrate the red blood cells in saline. The reason for this is when somebody is given blood, it's typically because they're lacking just the red blood cells and need more to help them transport oxygen through their body. They don't need all the plasma and all the other things that blood contains. And getting rid of antibodies that might be present in the plasma is even better for the patient. So look this over. If there's any questions, please feel free to ask. And that is the end of chapter 19. Know the parts of blood, plasma, white blood cells, erythrocytes, and know the function of each of them. Understand antigen and antibodies in transfusion, and understand clotting. I will be composing an email shortly which will give you some hints as to what there will be for essay questions on the exam, which will take place Monday. And then I will also tell you exactly what I want you to know for that clotting cascade. See you later.